You know, chest pain. It's probably one of the most common and most high-stakes things you'll see in medicine. You get it right, you save a life. You get it wrong, well, the consequences are no joke. That's why having a clear, systematic approach is absolutely crucial. So let's break down how to build one. Okay, so picture this. You're on shift, you're busy, and the next chart that pops up just says chest pain. What's the first thing that goes through your head? I mean, where do you even start? That's exactly what we're going to tackle today, using a classic case to build a really powerful framework. And to make this super practical, we're not just going to talk theory. We're going to follow a single patient case from the moment they walk in the door right through to the first critical decisions. This way, we can see how our systematic approach actually works in the real world. All right, so here's our patient. He's a 60-year-old guy, and his main complaint is chest pain. Now, right off the bat, that combination, age, male, chest pain, that should be like a flashing red light in your brain. This is a high-risk situation until we can prove without a doubt that it's not. So first things first, before we even think about ordering a test or laying a hand on him, we need to talk to the patient. Seriously, the story he tells you, what we call the history, is hands down the most powerful tool you have. The trick is knowing the right questions to ask. Think of these questions as building a profile of the pain. Was it sudden, like a lightning bolt, or did it kind of creep up on him? What does it feel like? Is it a crushing weight, like an elephant is sitting on his chest, or is it sharp and stabby? And where is it? Does it shoot down his left arm or up into his jaw? Is he sweating buckets, or can he not catch his breath? Every single answer is a crucial piece of the puzzle. Okay, so we've got the story of the pain itself, but we also need the backstory on the patient. Does this guy have high blood pressure? Is he a smoker? Does his dad or brother have a history of heart problems? These things don't give you the diagnosis on a silver platter, but man, they really dial up your suspicion for a major cardiac event. All right, so we've gathered all our clues from the history and the risk factors. The next step is to act like a detective and draw up a list of suspects. In medicine, we call this the differential diagnosis. It's basically our lineup of all the possible culprits. And as you can see, this list of suspects can be really long. I mean, it could be the heart, right? A heart attack, angina, but hey, it could also be coming from the lungs, maybe a blood clot or a collapse, or it could be something totally different, like the GI tract. Think severe heartburn. It could even just be inflammation in the rib cartilage. The real challenge is figuring out which one it is, and fast. So with all these possibilities, where do you even start? You start with this. This is the single most important rule in emergency medicine, period. You don't go looking for the most common cause first. You go looking for the most deadly cause first. You have to hunt down the killers. And that means our focus immediately narrows down to this must-not-miss list. We're talking about a myocardial infarction, that's a heart attack, a pulmonary embolism, which is a big blood clot in the lungs, and a pneumothorax, a collapsed lung. These are the things that can kill a patient in minutes or hours if you miss them. So pretty much everything we do next is designed to find or, hopefully, rule out these three big ones. Okay, so we've got our worst first mindset locked in. How do we actually hunt for these killers? Well, now it's time to get some objective data. We move on from what the patient is telling us to what we can actually measure and see for ourselves. And these are our go-to tools for that. We're going to check the vitals right away. Is his blood pressure tanking? We'll listen to his heart and lungs, and critically, we get an ECG, which gives us an electrical snapshot of the heart, a troponin blood test, which looks for a protein that leaks out when heart muscle is damaged, and a chest x-ray to get a quick look at the lungs. These tests give us hard, fast data.
Now here's something really important to understand. We don't always wait for all the test results to come back before we start treating. If our suspicion is high enough based on the story and what we're seeing right now, we have to act. We start treatment to stabilize the patient while we're still figuring things out. So let's go back to our 60-year-old guy. Let's say his story, his risk factors, and that initial ECG are all screaming heart attack. We are not going to sit around and wait for that troponin result to pop up on the computer. We are going to act right now.
And a really classic way to remember the first steps is the mnemonic MONA. That's M for morphine to help with the pain, O for oxygen if their levels are low, N for nitrates to open up those blood vessels, and A for aspirin to help stop the clot from getting bigger. It's a simple, powerful way to remember how to take immediate action.
Okay, so we just walked through the whole thing, from the patient walking in the door to the first life-saving treatments. So what's the big idea here? What's the main takeaway from all of this?
It really all boils down to this one simple truth. Having a system, A structured approach saves lives. Asking the right questions, thinking worst first, ordering the right tests. This isn't just a textbook exercise. It's how you bring order to the chaos of an emergency, and it's what gives your patient the best possible chance.
And look, if you forget everything else, remember this. Chest pain in a 60-year-old is a massive red flag until you've proven otherwise. You have to assume the worst until you have concrete evidence to back you down. It's that healthy dose of paranoia that's going to keep your patient safe.
And you know, this whole worst first way of thinking doesn't just apply to chest pain. What about a patient who comes in with the worst headache of their life? Or someone who suddenly can't breathe? The principles are exactly the same. Applying this systematic approach across different high-stakes scenarios is what truly elevates clinical reasoning. That's the framework that saves lives.